Okay, so folks are still coming in, but I think I'm going to go ahead and get started in the interest of everybody's time. So good afternoon, and thank you for joining us. My name is Karen Corman, and I have the privilege of being the Executive Director of your UIC Alumni Association. And welcome to our new series, the UIC Alumni Exchange. We will be hosting weekly events that bring you news, knowledge, and entertainment to help you explore, connect, and even escape from the everyday with a community of UIC alumni and faculty experts. You'll probably hear me say this a few times today, but I encourage you to visit go.uic.edu/alumni exchange for the latest and greatest programming. So a couple of housekeeping items as we get started here. I'm sure you've all noticed, but we muted you as you came into the room. That doesn't mean we don't want to hear from you. Please use your chat feature throughout and ask questions. Our team will make sure that we have time to answer those questions at the end and collect all of them. Please do be aware that this session is being recorded and will be available afterwards at the UIC Alumni Exchange website. We also recommend that you stay in speaker view, which if you're not familiar with Zoom, is in the upper right-hand corner of your Zoom app, because of course it's always better to see faces. And finally, you will receive a 30-second survey right after this presentation. Please do let us know your thoughts so we can continue to plan for the future. And with that, I'm excited to start our program this afternoon with Where Are We and Where Are We Going? COVID-19. And we welcome Professor Dr. Mark Dworkin, who is the School of Public Health's Associate Director of Epidemiology. Thank you, Dr. Dworkin, for being here with us, and I'm going to turn it over to you.
Okay, great. I'll go ahead and do screen share. And hopefully you see my slides just fine. So obviously we're doing an update on COVID-19. I had nothing to do at home and I thought this would be a fun way to spend an hour with a few friends. So here we go. Let's see, we already hit that slide. This is what I'm going to talk about during this presentation. Very quickly, I'm just going to go over some of the UIC School of Public Health COVID-related activities. I'm going to get into some background on COVID-19. I know a lot of us know quite a bit about it as we've been following it for a couple of months, but some people don't have as much of the infectious disease background. I just want to talk about a few things and a brief update on the global and the US data. Then I want to focus mostly on some questions that people ask and my responses to them. And at the end, I want to get to a little bit of hopeful news and some advice about coping with all this. And then there'll be some time for a question and answer period. So in terms of the School of Public Health, there's a number of activities that are going on. And this is just a selection of them right now, but there's been assistance to the Illinois Department of Public Health on their response to COVID through an intergovernmental agreement. There's been creating an epidemiologic model to track pediatric cases. There's been Occupational Health Services Institute consulting on preparations related to mitigation of COVID with major organizations and companies. Some of those are listed here. And there's been a variety of biostatistical modeling studies that have been done to estimate the number of COVID cases, both for the city, the county, and the state of Illinois. Now, as we go through these, I see that on my screen, I've got some photographic images of some of the participants on the right side, and it's covering up some of my slides. So hopefully that won't interfere too much with what I've got to talk about. So I wanted to say a little bit about the name COVID. Where does that even come from? It's obviously a new name. They started off by calling it, the Wuhan virus or Wuhan coronavirus. But COVID the co in COVID stands for corona, and the VI for virus, and the D for disease. So that's how that name. And then of course 19 because it began in 2019, although we're really getting hit with it in 2020. And there's other coronaviruses that humans have been dealing with long before there was this one. Coronaviruses infect humans and animals like cattle, camels, bats, and a number of other animals. And in humans, coronaviruses cause illnesses as mild as the common cold. Many people have had coronavirus infection. They never knew it. It's not commonly tested for because it's considered usually a relatively benign virus. Here's an image of the coronavirus. You can see how it basically has like a circle with some projections off of it. That's not unusual for a number of viruses. They have a similar kind of appearance as, like a circle with projections off of it. Other viruses have very different shape. This is the Ebola virus. We all hear about that in the news, and quite a remarkably different shape for a virus. There's also nothing new about having a multi-country outbreak of coronavirus. We had it with SARS, and we've had it with MERS. And so let me just talk briefly about those because we have some experience dealing with coronavirus in the past. I refer to SARS as when the genie first escaped the bottle because it was such a terrible outbreak and basically a pandemic. SARS-CoV is what it was called, and basically SARS coronavirus, or severe acute respiratory syndrome. And it's been thought that it's possibly of bat origin, although that's not been absolutely confirmed. In 2003, there were 8,422 cases in total, beginning in China, like this one has, and spreading to 28 countries. The case fatality rate ranged from 0 to 50%, so it was a very concerning event in terms of fatality. Fatality was lowest in the young and highest in those over 65, which is obviously familiar to us right now with this one. And there were successful control measures that were put into place that basically put the genie back in the bottle, which is not a small deal. When you think about it, this was a new virus that we had not experienced before, which meant everybody in the world was susceptible to it. We had no vaccine, and there was no effective treatment other than supportive treatment and ventilators for the very sick. And yet, despite that, using isolation of the sick, contact tracing, and quarantine measures, this virus in multiple countries was ultimately completely eliminated. In the history of humans, that is incredibly remarkable. There's very, very, very few instances where that's been done, and usually it's taken decades after a virus or disease has been with us for hundreds or thousands of years. And so this occurred in a matter of months, essentially. And so it really showed how far advanced we are now in terms of dealing with, potentially dealing with novel viruses. MERS is a similar coronavirus. It causes also severe respiratory illness in many people. And it's been shown to infect humans, bats, and camels. In 2012, there were 2,000 cases since 2012, began in Saudi Arabia and spread to 21 countries, and the case fatality rate has been around 34%. Again, successful control measures are used to contain this isolation, contact tracing, and quarantine. So and when we're hit with this COVID-19, it's not like we had no idea what to do or what to expect, even though it is not exactly the same as these others. So the COVID-19 coronavirus outbreak, with the latest worldwide data, shows that cases are already at more than 2.5 million worldwide, affecting 210 countries with 181,355 deaths. So it's obviously gone far beyond anything we've dealt with before with SARS or MERS. And if you look in the upper right-hand corner of the screen, you can see the number of cases reported per day over the last couple of months in the United States. And it looks like there's some flattening of the curve happening. You can see how things were quite steeply rising with number of cases reported each day. And then in recent times, it's more flat, but it's flat at a very high number of cases being reported. And also we have to keep in mind that there's more that goes into interpreting this. We can't just say everything flattened out, everything's good right now. Obviously it's not good because there's a lot of cases being reported every day. And also testing has been ramping up, which is also going to increase our recognition of cases so they can get reported. United States data shows that as of yesterday, 831,000 cases in the United States in all 50 states and at least 4 territories. And deaths as of yesterday, 46,013. Wow. So on the one hand, these numbers are terrible. And on the other hand, these numbers are not as terrible as they would be if we hadn't done a lot of things that have been put into place so far. Obviously, we're all doing them. That's why I'm talking to you from home. That's why you're probably listening to me from home. Now here's some data that we got for Illinois, number of cases per day reported, smoothed, which means basically we took 3-day moving average. And you can see here also based on these data that it looks like in Illinois, there may be some flattening of the curve that's going on right now. I would expect that's probably the truth of what's happening. Again, like I said, there's other factors that may be in play. We're having more and more testing going on. But I think that that we have probably hit a region of time where we are accomplishing what we were trying to accomplish with this social distancing. One of the questions that gets asked sometimes is, can mailed packages transfer COVID-19 virus? We imagine the outbreak being out of control, for example, in China as it was, and then getting a lot of things shipped to the United States through Amazon or other methods. And basically, there's only a theoretical risk. It doesn't survive on cardboard very long. Experimental data suggests it doesn't survive 24 hours, so we would expect that most likely by the time it arrived in the mail, that wouldn't be even an issue. But then again, we've heard of people getting sick from who work in Amazon.com warehouses. So yeah, I suppose there's some risk there, but it's not how we basically are talking about this virus getting transmitted from person to person. And if anybody had a concern about that, you could always just let your package just sit, for a day if that was actually a concern. Another thing I hear sometimes is, will warm weather stop this outbreak? For example, it'll go down a lot during the summer. We see that with flu, so that's made people wonder if that could be the case. Basically, the answer is we don't know, but no, I don't think that's what we're going to see at all. Some other viruses like coronavirus, I can't even read my screen, but I think it probably says coronavirus and flu. They spread more during the winter months. However, disease is being reported from India. I mean, I looked at the temperature in India, and they've had highs of 100 degrees or higher. So there seems to be no problem with coronavirus spreading during warm weather. And so I don't think that's part of the equation, at least not for now. Can your house pet get the virus, and can it give it to you? Here, again, it's more of a theoretical risk. We do know that animals can get coronaviruses. They have in the past. There are some that circulate in animals. And we've heard of at least a couple of instances where a house pet, like a cat, got coronavirus. But in terms of spreading coronavirus, so far, that's not something that we're hearing about. It might be something we hear about in the future. Everything's new. We're learning every day about this disease. But currently, no, that's not a major issue. However, if somebody is ill and they might have coronavirus, or they do, and there's a house pet, then it would be intelligent to restrict the actions of the house pet, that they're not hanging out with the ill person, or that they're only hanging out with the ill person, because you wouldn't want the ill person coughing and petting and so on the animal. Then the animal goes into another room shortly after that and basically can move the virus around while it's still, viable. Who should wear a mask? This has been an evolving issue. As you talked to me, 6 weeks ago, I would have said one thing. Now I'm saying something totally different. But we do know that, of course, anybody who has respiratory symptoms should be having a mask if they're going to be around anybody else. If you are providing care to an individual, like somebody in your home, then it would be important, if they're suspecting that they have COVID, or they have COVID, that would be important for you to wear a mask. And certainly the healthcare workers, we've heard a lot about that. But generally speaking, in terms of public masking, if you're going to be among people where you cannot guarantee social distancing, that's when the mask is most important. If you're going out for a jog, you're not going to be around anybody or anywhere close to anybody, then you might keep the mask in your back pocket, but you basically are not likely to need the mask. But if you're going to Costco, grocery store, or whatever, then it makes some sense to be bringing that mask. Now, why? Well, the main reason is, if you are potentially going to be getting this disease, if you have asymptomatic disease, you don't have symptoms, but you might have the virus, you're protecting others. And then there's, to some smaller extent, you're protecting yourself from getting it as well if you're around other people. Now, why are some cities or regions experiencing a worse outbreak than other places? This question gets asked sometimes. Why New York City has been hit so bad? And there's a lot of factors that can influence the impact of COVID-19. How long ago the virus was introduced to an area? In fact, it looks like California had introduction of the virus from some recent data, at least back in December. Population density, New York, obviously a very dense area for people. Chicago too, New York even more. Age distribution, we know that where we have older people, there has been higher illness rates, hospitalization, and mortality. So age distribution could affect what we're seeing. Prevalence of underlying medical conditions. We know that certain medical conditions are predisposing to worse disease, like diabetes, like obesity, and like hypertension. And the timing and the extent of community mitigation measures is going to make a difference. The longer it took for leaders to put into place, encouraging social distancing, for example, the more time the virus has to spread easily from person to person without getting interrupted. And diagnostic testing capacity is going to make a big difference. Wherever they pushed for more testing sooner, they likely found more cases, and that makes it look like they have a worse outbreak than someplace else that might not be doing as much testing, but might actually have just as bad of an outbreak. And public health reporting practices, right? It always matters if and how quickly cases are getting reported and how well they're being reported to the health department so they can be counted to even look at the data. Now, if I have COVID-19, when can I get out of isolation? This is another thing people wonder about. The guidance changes, as you can see, it's interim CDC guidance, but currently what's being recommended is that if you were sick with COVID, you'd have to wait at least 3 days since the fever resolved, and you'd have to have your respiratory symptoms have improved, and it's got to be at least 7 days since the symptoms first appeared. Or if you have 2 negative tests, at least 2 days apart, that would also get you out of isolation. If you were not sick, but you did test positive, then you would have to wait 7 days since the test was positive, and no symptoms should have developed during this time period. And you're expected then to wear a mouth covering like a mask or bandana and social distance yourself for another 3 days after you get out. I think everybody knows the basic protective measures against this virus about washing your hands regularly and thoroughly. You can use alcohol-based hand sanitizer. Soap and water is, I think the best, but obviously we don't always have that handy. And maintain social distancing. We often talked about 3 feet when we talk about droplet infections, but for this one, it's been said from early on 6 feet. And I think that's wise. This seems to be a highly contagious virus. Avoid touching eyes, nose, and mouth. A study showed in 2015 how commonly we touch our face. In terms of college students, touch their face with their own hands on average 23 times per hour. And then respiratory hygiene. Covering your mouth and nose, when you cough or sneeze is obviously very important. Now, can someone spread the virus without being sick? The answer to this is yes, although symptoms often appear 2 to 14 days after exposure, and that's when they're most contagious. Transmission might occur a few days before the illness begins, and this is why this public masking has become important, because since we don't know who's getting it and who's asymptomatic but can spread it, it becomes really important to just block that droplet from flying out of the mouth, which is what happens when we talk. We don't always think about that, but we do. Now, just how contagious is COVID? This is something we'd all like to have an idea of. I mean, when we talk about infectious diseases, this one we can really say is highly contagious. Here's an example of that I think is relevant to our recent talk about opening the economy. Um, a report of an outbreak appeared in the CDC's MMWR among restaurant diners from China. This had occurred January, February, and it's really a nice example of what we have to consider. There were 3 unrelated families that had lunch at this restaurant at the same time. So they're seated separately from each other. Now, one person at one of the tables developed symptoms later that day. Not they hadn't had symptoms yet when they were dining and having lunch. They weren't coughing when they were dining. And then this person, 4 others at her table, and then 3 others at a nearby table, and 2 others at yet another table, all ended up becoming COVID-19 cases within 2 weeks of this lunch. And you can see the seating at this restaurant. I mean, there are other tables outside of this area, but here's the table A is the table where this so-called index case was seated. And you can see how several people at their table, but also at table B and table C, these other families became COVID cases. And you can see there's an air conditioner there on the far right side that was blowing air. And you would think maybe that would somehow blow air and protect table C, by pushing the air away from them. But that's not at all what occurred. There was apparently not great ventilation in this particular restaurant. And so COVID virus was apparently coming out of somebody's mouth, going into the air and moving around. These tables were 3 feet apart. I think that's really important going forward. When we talk about reopening the economy, when we talk about restaurants and so on, it's going to be important to keep this sort of scenario in mind, air circulation in mind, and probably there'll be a lot more outdoor seating. I think that if restaurants want to open during these warm weather months, it will make sense that we do a little more outdoor seating. What about persistence on inanimate surfaces? It remains infectious from 2 hours up to 9 days, depending on what surface we're talking about. It persists longer if there's lower temperatures, like we are now leaving these lower temperatures of the winter, so that's good. Persistence is also longer if more of the virus contaminates a surface. In other words, if somebody coughed and the droplet, let's say hit a door handle, then that's probably going to be more virus than, let's say, if somebody's finger was contaminated and touched the door handle. It's all theoretical, though. And then high humidity probably allows the virus to survive longer, too. And that's a negative. We're going into this warmer weather. That might be good for the virus not doing so well, but on the other hand, it'll be humid, and that'll favor the virus. So a lot of factors in play. This data is interesting because it shows different surfaces and how long under some experimental conditions the virus can survive. You can see on steel, we're talking about the virus surviving for a number of days. On glass, the virus can survive for a number of days. Aluminum, we're talking about hours. So different surfaces make a difference for survival. This is important if we're thinking about how often we need to clean things. I think basically the idea is if we're going to deal with this virus, and if this virus is going to cause us so much distraction, that basically we should be cleaning surfaces, public surfaces, as frequently as feasible. Cleaning with what? Well, there's a number of things that can be used. Ethanol, like rubbing alcohol, is one thing to consider. Diluted bleach is another, and you can see here a little information. We're not going to go into it, but it's readily available on the internet. I want to also bring up the importance of notifying the health department of any clusters of cases. Health department definitely needs to know, because they need to get in as soon as they can. So the sooner they know, the better. So if you hear about a family member who's, let's say, at a nursing home or a jail, some sort of group home shelter, whatever, any kind of congregate setting, it's really important to make sure the health department knows. Don't just assume somebody's going to tell them. I'm sure they'd rather hear twice than not at all, or delayed. Where are we going in terms of predicting the future? Obviously, nobody can say with any certainty, but we can give you an idea of what to expect. As case counts decline, these policies are going to lead us to some sort of new normal, and they'll be guided by several factors. And one of the factors that we have to consider is the ability to determine who has COVID and needs isolation. So this is where we keep talking about test, test, test. We need to have a lot of readily available tests so we can know who's got COVID versus who's got pneumonia due to some other reason or some other fever illness. The ability to identify close contacts is still really important, and it's going to become even more important going forward, because again, we want to get back to this issue of finding people's close contacts so we can make sure they're alerted to monitor themselves and maybe quarantine and limit the spread that way. And if they become symptomatic right away, get testing, determine if they're a case. It's also going to depend on our ability to determine who is immune. And so we talk about serology testing and, basically who actually has already had it. And we hope they'll be immune for a long time, maybe lifelong, maybe months. We don't know yet. So that's all a mystery that's going to get discovered over the coming year or so. We are also interested in the regional burden of disease. Obviously, some places are going to get harder hit than others, and some places are going to recover sooner than others. We're going to watch this happening differentially. Public compliance with prevention measures is also super important. Where there's less compliance with prevention measures, we're going to expect there's going to be more disease, and that's going to affect the impact of reopening. What might a new normal look like? Well, until we get an effective, safe vaccine, we're going to have some level of continuing social distancing, especially for highest risk persons based on their higher mortality. The elderly, people with diabetes, people with hypertension, morbid obesity. We really need to protect these people, just like with a disease like whooping cough. We talk about cocooning, where we're trying to make sure there's immunization of the people who are closest to the babies so they don't get whooping cough and die. And so it's kind of like a similar kind of thing has to happen here with our social distancing. I mean, some of us are going to get to go out and take more chances, going to opening restaurants or malls or whatever is going to happen next. And but really people who are the elderly, those with diabetes, hypertension, and so on, they're really going to have to think twice about how quickly they're going to come out from their homes because of what's at stake here, unless they've already had the disease, survived it, and we know they have some immunity, and we know that immunity lasts. But that's a special population. I think we're going to see opening of businesses in stages with modifications. I bet we're going to see things like fever and symptom screening when you're trying to go into certain places. Masks for all when we're near others is likely to continue. Well, I say masks or some other face covering, like a bandana or so on. Enhanced access to hand hygiene is going to be really important. Spacing out, such as at restaurants, theaters, stadiums. I can see how these things will eventually become available, but they're going to be done differently if they're done smartly. Fewer tables at the restaurant or more outdoor seating spread apart. At the theaters, they may choose to open, but then have only certain seats available. I'm not sure how they're going to do it, but when they do it, if this is still going on, it's going to need to be that there's going to be more impact to the economy in terms of how they do this. Disposable menus probably we'll see, where it's like a paper menu, and we're not using the same menu that somebody used at a table just a short while ago. And many in-person meetings are going to continue to be held online. I think that's all working out much better than I'd ever expected it to. And airplanes are probably going to reduce seats when they first, open up and enhance their airflow, which I think they already have done. So there'll be a lot of measures. I mean, probably too many for me to list here, but I can imagine a lot of things that will be different. I'd also like to talk about a little hopeful news. This is just one example of hopeful news. There's a Japanese drug that may be effective at treating COVID-19. It's called Revere. And it's had preliminary data that suggests it's most useful to treat disease early, which seems to be the case for a lot of COVID-related treatments before they become critically ill. They showed in the small study that X-rays improved in about 91% of the patients who were treated with it versus 62% in those not treated. And a US small clinical trial is supposed to begin in Massachusetts if it already hasn't. There's a lot of other studies going on. I just thought this one was interesting. I also want to emphasize how this has kind of been obviously a big emotional burden on us all, how disruptive it's been for everybody. I want to emphasize that this is all temporary, that the worst has probably been occurring now. I sure hope I'm not wrong about that. And that our knowledge about the virus improves every week. So we only get smarter and better with what we do with this virus. That's really important to keep in mind. And that's going to keep happening. And we need to be patient with those who are trying to provide us with guidance in this setting of basically something historically new. The guidance is going to keep changing. Um, Beware of letting fear, which the TV seems to be excellent at promoting, fear, discomfort, and exhaustion with this situation allow you to justify dismissing good advice. Because we all get tired and eventually apathetic of doing some of these things, but we've got to maintain our reasoned judgment. And also, most people who have gotten the disease have or will recover and probably have some protection going forward. And the more of those that there are, even though we don't want people to get the disease, the more people who have had it, the more dead ends there are for the virus. When the virus comes to them again, most likely they'll have immunity or partial immunity, whatever, and they are likely to be not transmitting the virus. That's certainly what we expect based on a lot of other viruses. I also want to address briefly stress and anxiety during this social distancing. Some of us are alone, keeping the TV or phone screen active all day. Some of us are living with children who are restless and bored. And some of us are living with adolescents or college students who are in conflict with their parents. And the more time we spend with them, we're spending more time than ever before at a time when they're normally, getting spaced from their parents. Some of us are trying to work in a home environment with distractions from others. You don't know it, but just a moment ago, my dog ran in here, having escaped from my wife, and I didn't flinch. I'm getting used to this. Some of us are leaving the house every day to perform essential services like healthcare or grocery store work, concerned for a risk to ourselves and others. And most of us are watching television and hearing bad news every day. I have to watch the television. I want to hear what's going on. I want to hear the updates. But man, do they use a lot of hyperbole, and they sure use a lot of adjectives like chaos and fear and unprecedented, and all words that I suppose are somewhat accurate. But man, hearing that over and over again every hour, the same news reported, it's tough. So I want to come back then to keep in mind again, this is temporary. We will get through this. Treatment studies will help the sick. Just this morning, I was on a phone call with an infectious disease practice, and I was hearing some optimistic news about one of the treatments that they're using that was significantly helping the patients survive their intensive care unit course after being put on a ventilator. It's just preliminary information, but that was really good to hear that kind of thing happening. There's a number of vaccines that are being tested, and we'll probably have some good luck with that. And we do need to expect another wave of cases at some point. Don't be surprised by it. We should plan for it. Make sure you have the supplies you need in your house for a future wave when this all starts to lighten up a little bit. And again, don't emotionally let yourself be too frustrated. Expect it to happen, because that's we hope it doesn't, but it's likely that this disease will occur in waves until we are able to really suppress it with something like an effective vaccine. Definitely check on your neighbors. It feels good to do so, and it's important because some of our neighbors, are all alone and may not be Zooming with friends and doing other things and technically capable. And make use of technology to find your support systems. Keep in touch with friends, family, faith-based organizations. And again, just take this one day at a time. We all are, I think, antsy to be moving on to something so much less restrictive than this, and we will. But let's just try to deal with this in terms of just understanding that this is not going to happen quickly. As some people refer to it, it's not a sprint, it's a marathon. And so we need to keep that in mind. I'd like to acknowledge one of our students who helped with the development of some of these slides. And with that, I'll conclude and turn it back over.
Well, thank you, Dr. Dworkin. What an incredible amount of information and providing some clarity. We can see there's lots of questions coming into the chat, so I will read some questions if you don't mind answering them. And let me start with, it seems to this person that unless there's global collaboration and a unified global strategies for dealing with COVID-19, the situation will not improve permanently. Why isn't anyone talking about this?
Okay, well, in terms of global collaboration, that's always been a challenge for, yeah, obviously for a number of issues. No surprise here that we don't have full global collaboration. Our countries are led by political leaders who are both very different from each other and sometimes different from large groups within their own population. So this is what we have to deal with. However, let's also remember that there have been times in human history where we have successfully eliminated and eradicated a disease. The smallpox being an example, it was done globally with a vaccine and with identifying close contacts. And so even with civil wars in some countries and you know, big differences in leaders, it is something that we can do. And so I still maintain some optimism about it.
Great, thank you. Next question. Do you attribute increased difficulty in containing COVID-19 versus SARS to the fact that SARS almost always presented as severe and incapacitating, whereas COVID can cause mild illness and those with active infections are often still able to go out and participate in public life? I've heard that SARS actually has a higher RO than COVID-19.
Yeah, I mean, I think it'll take some time before we figure that out. You know, we don't feel, I don't feel like we have all the information of what exactly happened when this thing was emerging. China may have had its own reasons for, you know, withholding information. I just need more facts to figure out the answer to that question. And, you know, one of my concerns is that, you know, not as much was done as well as it needed to be for this particular virus. And it sure is highly infectious. I think it's more infectious.
Thank you. Has a successful vaccination ever been developed, or sorry, a successful vaccine ever been developed for any coronavirus in the past?
I'm not aware of one.
This question said, or I guess it's more than a statement perhaps. I'm hoping to hear something about mutations in the virus and in recent news that some circulating variants are much more virulent than others.
Yeah, I think that's something that we still have to work out. Different strains of the virus, how quickly does it mutate? That's going to make a big difference in terms of what happens with the vaccine and its potential success. It's one thing to get a safe vaccine. It's another thing to get a vaccine that's highly effective. We talk about our flu vaccines. We have to change them every year because of the changes that can occur in the virus. And we don't know to what extent we're going to have to deal with that. We also talk about our flu vaccines and how different populations have better or worse efficacy of the vaccine. And so, you know, are people with diabetes going to not have as good protection from the vaccine as other people? That's what we see with flu. They don't have as good protection, you know, because it affects their immune system, diabetes does. So we've got a lot to learn still, but we're just at the beginning.
Next question is, do we know if UV light kills this virus?
That's something that I looked at a long time ago, and now I can't remember the precise information, but I believe the answer is yes, to some extent that can make a difference. It certainly makes a difference for a number of organisms. Also, we don't necessarily think about it as being killed as inactivated.
So it's a good distinction. Another question is, does COVID live on jewelry services such as gold, silver, or gems?
I haven't seen tests. I haven't seen any research on that. it wouldn't surprise me if it doesn't do as well on some of these kinds of metals, just like it didn't do as well on aluminum. I wonder if certain metals are, more inhibitive or in some way.
What is the most effective material to use for masks if no medical masks are available? Cotton, polyester, other materials?
Well, I mean, really, a lot has to do with the weave. If the tighter the weave, the better. But generally speaking, most of these things, it's fine, because you're really, like I said before, a big part of it is blocking a drop from you coming into the environment. And the more of us that do that, the better. We don't expect for most of these things that any significant number of drops are going to fly out from a mask, given the size of these drops.
That's very helpful. Does COVID-19 aerosolize?
Well, there's definitely conditions in the hospital where it looks like it does aerosolize. And it does seem to float in the air a little bit, based on some of the hospital work that's been done, where they'll like find it in the hallway floor, places where the COVID patient hasn't necessarily been. So to some extent, this seems to be occurring, but we don't have excellent information on that. It's best to assume that it is so to some extent, but that most of the transmission is droplet.
With states like South Carolina and Georgia opening up for business and public spaces, what do you think the impact will be?
Well, I mean, based on what we know, I would expect that it really depends on how they open, right? If they open with a lot of testing and a lot of restrictions that are, mindful for eliminating risk or reducing risk, then they might do okay. But most likely, it's so quick to be reopening, even though I'm anxious for reopening. I worry that we'll watch them get an upsurge, and it'll be a natural experiment that we'll all learn from.
Yeah, I agree. Does it make sense to get a pneumonia vaccination right now?
Pneumonia vaccine. Well, the pneumonia vaccine is for pneumococcal disease, and if people are at risk for pneumococcal disease, they should get it. There are guidelines for pneumococcal vaccination, such as people who are older than 65, people with certain conditions. Best to contact your healthcare provider if that's a question, to see if you're eligible.
What type of data do we need to determine whether past infection confers immunity, and for how long?
Well, we need a cohort of people to follow them, basically, who are proven to have had the disease, such as with diagnosis of COVID or antibody testing, and then to follow them over time. And so special and time-consuming studies are going to be needed to get good information on that.
I think that you may have addressed this a little bit before, just as the information continues to change, but the question is, how does concentration and exposure time affect someone's chance of catching the virus?
Concentration, such as the amount of virus that you're exposed to, definitely seems to play a role. And I would suspect that, like other diseases, the more that you encounter, the sicker you might get. The more virus that enters your body at one time. So somebody who's, let's say, taking care of somebody with COVID and not wearing a mask and not being very careful, or didn't know to be very careful because it was early on in the outbreak, they may encounter a large amount of virus compared to somebody else who just handled a door handle or something like that.
Are we frozen?
Can't hear anybody at the moment.
Okay, there. Are we back?
Yeah.
Okay, sorry for that little glitch. So thank you for that answer. The next question is, at what age do you consider a person elderly? And maybe this isn't necessarily your consideration, but how it's being determined.
Yeah, it's more of an adjective than anything else. You see cutoffs that are used in studies like over 65. It's a continual number. So basically, when you look at the deaths, you see that they really start to rise in the 50s, and then more in the 60s, and then even more in the 70s, and then the 80s and 90s. You're seeing the largest amount. And so you can draw your line anywhere, but it's more of an issue of the older you are, the higher the risk, but also the higher the risk that you might have picked up one of these comorbid conditions that puts you at higher risk, like high blood pressure, obesity, um, diabetes. So there's a lot in play, but certainly the older we are, the higher the risk for problems.
More challenging. Okay, the next question. I saw something about permanent lung damage. Is that true, and to what extent?
Yeah, I haven't seen enough on that. I haven't looked into it yet. It would make sense that there would be some permanent lung damage for some people. Um, I mean, just being ill enough that you're in an intensive care unit, you're put on a ventilator, that your oxygenation status was damaged so much that you needed a ventilator. Um, certainly there could be some chronic lung problems that we will see after this. I'm afraid for that too.
Continued aftermath. I'm positive I'm about to get a word wrong, so I'm going to excuse myself as I start to read this. What are the future implications for comorbidities?
Comorbidities.
Okay, comorbidities, thank you. Like diabetes and hypertension among Brown and Black communities now that there is a dialogue regarding the racial disparities in Cook County because of the high mortality rates.
Well, I think that this is bringing up an important point. We've got health disparities. So there's lots of people, globally who have hypertension, obesity, and so on, diabetes. But there's health disparities with these problems in the minority communities. And so we need to be protecting these people as much as we can. There needs to be a heightened awareness of these risk factors for severe disease. There needs to be enhanced protection of people with these conditions, because these conditions are making it worse. They're causing greater hospitalization. They're causing greater death. And so, it's both an opportunity to shine a light on the problem of health disparities, but also in the moment, it's important too that we do what we can to protect, auntie, grandma, whoever, if they have these problems, and help them out with prolonged social distancing to get them through this period till we've got a vaccine.
Thank you. What about the guidelines for treatment from the NIH? Are they useful?
Well, in terms of treatment guidelines, so far, what I've seen has not been very specific in terms of the usefulness, because we don't have a lot of studies results yet. So there's not a lot that can be recommended at this time. This is something that we should watch and will evolve over time.
Thank you.
A lot of what's being done now is physicians as groups or individuals, making choices based on what little information they have and trying things out.
And evolving, I imagine. Okay, so based on how quickly we are learning about this disease, will we know this summer whether we'll be safe to go back to work and school in September?
Well, will it be safe? Of course, the issue there is risk mitigation. What is being done in that workplace to minimize risk? Social distancing is going to need to continue, but it can be introduced into a workplace if we've got high compliance and mindfulness to it, on a regular basis, and frequent environmental cleaning, and some level of masking or mouth covering and so on. So what I refer to as the new normal is it's going to involve things like this again until we get a vaccine, because we're stuck with this virus now, and we know what harm it can do, and we need to do what we can to block it. But we also need what we can do to make sure our economy is functioning. Obviously, our tax dollars will be affected by this, and our tax dollars are needed by our public health people to use to employ their people and so on. So it's it cuts both ways. So we do need to do what we can to safely open as much of the economy up as we can.
A bit of a vicious circle in many ways, I think. Okay, our next question. We talk a lot about testing, but what is being done to ensure and get more tests? And there's two parts. And how many tests are reasonably possible to aim for? Having some people say a million a day, but is that actually reasonable?
Yeah, I mean, this sort of decision making is totally outside of my day-to-day work. I can only make a general statement. The more testing, the better, as long as it's feasible and it is accurate. We've got a flood of new tests that are coming out there, and the problem is that we're not talking about FDA-approved tests and validated tests. So more testing isn't necessarily better if it's not good quality testing. But we need good quality testing as fast as we can. We need as much of it as we can, because the better we are at recognizing who's who, a case, not a case, immune, not immune, the easier we can be with sorting ourselves and taking precautions and knowing when we can relax precautions.
Yeah, I think it goes back to your comment about the news and just hearing all these different things. It's hard to disseminate what is actually needed and possible. So do you think we'll be dealing with the waves of COVID-19 until 2022, like some of the articles are saying?
Well, everything depends on that first vaccine and how safe and effective it is. It's certainly possible and likely we would be dealing with it in some way in 2022. I would expect that we would be dealing with it in some way, even if that's rolling out vaccine.
Yeah, I would agree. Are there studies showing that people with autoimmune diseases are more at risk?
That's not what I've seen so far. I haven't seen a lot of data, but I know that my personal anecdotal experience has not been that that's been a big thing yet.
Okay. Is the pneumonia that people get with COVID, I'm sorry, let me read that again. Is pneumonia that people get with COVID get different from these words? I don't know how to say this. So you said it earlier. So I'm going to spell it. Pneumoccoccal.
Okay.
Pneumonia. I'm sorry, I don't know how to say that.
Generally speaking, yeah, that one, pneumococcal pneumonia, is a bacterial pneumonia. It tends to cause a certain area of your lung to get affected. Usually, that one can get worse than that, but that's the classic, is like, one lobe of the lung, is affected, that kind of a thing. This is worse. It's more diffuse. It seems to be progressive, much more progressive, and when it causes its severe disease.
Thank you for correcting, since that's not a familiar word that I say on a daily basis by any means. I think we have time for one last question. So last question being is, should I be wiping down my groceries?
Okay, that's a good question. And the answer is, go ahead and do that. But I don't know if you need to. There's some theoretical sense to it. What if somebody spoke or coughed who was near your groceries? Then technically you might be bringing the virus in. What's the likelihood of that? Not real high. But what's the feeling you're going to get from having wiped down your groceries? Some sense of security, and that's worth something. So yeah, I mean, I haven't heard of anybody who got sick from the groceries, but then again, how would we figure that out? We'd need a real lucky case to even match that. But the theoretical risk, it's there.
Thank you. I know people have been debating, so I think that's, to your point, it's helpful if it makes you feel better too. So, well, Dr. Dworkin, thank you so much for spending your time and sharing your expertise with us. This has just been incredible. I would encourage our participants to visit Public Health's website, which we will send out and was at the beginning of this presentation, for more information as it continues to evolve, as Dr. Dworkin has said several times. Next week, please join us on Friday, May 1st for our next UIC Alumni Exchange event at noon, featuring a two-time alumnus, Jason Walk. and former historian who will discuss with us from Navy Pier to Here, a UIC history discussion. You can find more information at go.uic.edu /alumni exchange. And then, of course, as I mentioned before, we will be sending out a survey afterwards. So please take a few minutes to just, not even a few minutes, it's 30 seconds, I promise, of your time to give us some feedback. Thank you again, Dr. Dworkin. Thank you to all our participants for your great questions and interaction. We really appreciate you and joining us today, and we look forward to seeing you again at a future UIC Alumni Exchange. Have a great rest of your day.